Good morning and welcome to Perioperative Electrolytes, focusing mostly on sodium and potassium in late 2015. Let's start with a case example. 55-year-old female for free flap is scheduled for 12 hours. Past medical history includes laryngeal cancer, hypertension, COPD, peripheral vascular disease. As typical, you send serial ABGs to trend the progress and mostly focusing on volume status and trying to keep track of blood loss, even though that's such a challenge in those cases. What we tend to see is a mild progressive increase in the lactate. So let's place a scenario. After 7 hours, it's up to 1.9. The base deficit, however, has increased more significantly and is -9 at hour 7. So we're focusing mostly on base deficit. Think to yourself for a few seconds before I give it away why that would be the case. Why, after 7 hours of minimal blood loss, minimal surgical stress response, do we have a progressive base deficit in this case? Alternatively, here are some clues. Is it due to progressive hypovolemia? Is it just sampling error? Is it a consequence of normal saline IV administration? Or is there increasing inflammation, like I alluded to already with the neuroendocrine stress response? As is typical of a good test question, one of the distractors is what commonly is what people think is happening. So the two realities here is that you're trying to differentiate side effects of normal saline administration from progressive hypovolemia, and that's what we're going to focus on. Be very careful when you're evaluating base deficit as a volume status indicator. When a patient comes in emergently, say a gunshot wound to the leg and has a severe base deficit, that's a good indication, because the patient has had large volume resuscitation that we'll talk about shortly, of the patient's volume status. After hours and hours of being under anesthesia with maintenance fluid going, you have to be aware of some subtle changes that happen. So let's look at the two that we use most commonly here at UK for crystalloid maintenance, LR and saline. You're pretty familiar with these. In neuro, we use the saline more preferred because of the higher osmolality. The sodiums aren't really that much different if you consider, we'll just call 140 normal. But notice the difference in the chloride. That's pretty substantial. The normal range for chloride is 101 to 108 at UK, if I have it right in my head. And that's pretty close. It's just on the higher side for the LR. But let's take a case instead where you're managing with normal saline. That 154 is quite a bit disproportionately higher than physiologic chloride. This has a very relevant physiologic and then therefore clinical relevance, however, because what it ends up doing is misleading you. And we have seen this happen repeatedly, and even last week I got called from my nurse anesthetist during a crani to say, is this increased base deficit indicative of being behind in fluid status? And that's the entire theme of what I'm focusing on right now. Because we're using normal saline, because it has elevated chloride compared to physiology, it will mislead you. Let's get into that a little bit more. As you all know, bicarb is the most active buffer in your body. You've been asked that question since pre-medical time. Base deficit itself, the lab that we look at routinely on an ABG, is determined mostly by the bicarb. Consumption of bicarb in a trauma case, for example, means there's less bicarb or that there's a base deficit, which can be expressed by calculating how much base is needed to normalize the pH back to 7.4. Base deficit, how much base is needed to normalize the pH. You can conceptualize this also as a manifestation of the strong ion difference. This is cut and pasted from Pearls, I think, but to keep it short here, you can read through what I have copied here, but the strong ion difference is simply the net charge balance between the strong cations and the strong anions. If you think back to this slide on LR versus saline, that chloride is disproportionately higher, which means all that extra chloride floating around is making your strong ion difference decreased. So if you have extra chloride, then your positives minus your negative end up getting smaller and smaller. This leads to increased H+, and that gets translated into an increased base deficit. Now you're asking yourself, why are we talking about chloride the entire time on a lecture on sodium and potassium? But this is something that really will come up clinically, and I don't want you to be the person who gets the fluid assessment wrong. So think of a craniotomy room where we run preferentially normal saline, or the time where it comes up literally every day, all day long, is in neurocritical care, where the patients are often on hypertonic saline, so 1.5 or 3% saline, trying to drive up the osmolality so that the brain will shrink down and limit herniation or malperfusion. What we've done at UK in neuroanesthesia is change the protocols, because it can get complicated to interpret the blood gas analysis with volume status if someone's on large volume normal saline. And it doesn't have to be just large boluses like on a level 1, just a few liters worth of normal saline. All that chloride really messes up, for me at least, my ability to interpret my volume status. If you keep it simple and don't commit to just using your base deficit as an indicator that you're getting behind on fluid, you'll do better. If you are concerned about it, alternate saline and LR or switch to LR. That's what we do in neuroanesthesia. We get rid of the chloride and just go to the LR, so it's more physiologic. You can also use your other volume status indicators. So we have pulse pressure variation on almost all the machines, and if not, you can hook a flow track up pretty easily. Keep in mind, CVP may have some utility, but it's not very clear. We're going to switch gears now and focus more directly on sodium and potassium. Here's a slide from a few months ago on Cushing's disease. Remember, Cushing's disease is excess ACTH. Excess ACTH to us means excess cortisol. I use Cushing's disease not because that's the focus so much here, but as a direct comparison to adrenal insufficiency. And it's how I keep it straight in my head. So if I can remember one or the other one day, it helps me remember the other half of the pair. So if I can remember the details of Cushing's disease on Tuesday, then I can remember adrenal insufficiency. And if it's vice versa, it still comes out helping me. That's how I get through these things. So excess cortisol causes the things you see here. So glucose intolerance, diabetes, hypernatremia, that's why we're bringing it up here, hypertension, and hypokalemia. So here's a question that I wrote a few months ago. Which of the following lab abnormalities is associated with Cushing's disease? Well, this should be pretty easy since I have the symptoms written out here, or the manifestations written out. But you end up with a hypokalemic metabolic alkalosis. This is really helpful for me because without comparing it to adrenal insufficiency, I find myself getting confused. Dr. Peterstein asked me out of the blue yesterday to differentiate myasthenia gravis from Eaton-Lambert or myasthenic syndrome. And although I got it right, I certainly hesitated, because as easy as those things are to keep in your head when you're reading about them or studying or preparing for an exam, clinically sometimes it's hard to keep them straight. So I try to find pairings like what I have here, Cushing's disease paired to adrenal insufficiency, to help me make sure I don't make a mistake clinically. Let me get more to the point here. Adrenal insufficiency is associated with both cortisol and mineralocorticoid deficiency. And what that means to me is it's the opposite of Cushing's disease. So if I have hypernatremia detailed here under Cushing, under excess cortisol, and hypokalemia, to me that means adrenal insufficiency is going to be the opposite. And I hope that this little tidbit of memory jostling can help you clinically to come out ahead too. So adrenal insufficiency to me is low sodium, elevated potassium. Hypercortisolemia is the opposite of that. Now the problem becomes, and this is classic oral boards fodder, hyponatremia and elective surgery. How low is too low, and when do you proceed? Well, as I think we've already taught you, even if you're in your first or second year here, committing to a number is not the right answer so much as trying to integrate all the variables. So let's take a specific example. Sodium is 125. If normal is 140, do you proceed with elective surgery or not? Well, if you say, yeah, I'll do 125, what about 123? What about 120? At some point you'll be painted into that clinical corner. And I've seen at least one of the vascular neurosurgeons do this clinically in real time. Well, sure, you said you won't do the case at 125. If it were 127, would you have done it? If it were 128? And what you want to do is try to avoid being painted into that corner. In reality, what am I supposed to teach you here? Well, it's difficult to work through. You have colleagues all around you, rely on them. Um, it's a different thing when you come and say, well, Dr. Locke and I talked about it, and we thought this would be too much perioperative risk until we get this normalized. It depends on the clinical situation as well. So I have an anecdote, I think it was with Dr. Zenos, where a patient for a major vascular, revascularization of the lower extremities presents. Little old lady, we had seen her a few months ago, and she had a fairly normal sodium, like 138. It was a little low. She presents a few weeks later for revascularization, and her sodium's in the mid to upper 120s. We'll call it 128 today. And I have to talk to the surgeons and say, look, we've had historically evidence that she was normonatremic. Something is very different now. Maybe she's malnourished because she's chronically ill at this point, certainly possible. But what I used to defend not doing the case electively were two things. One, if it's just an endovascular revascularization that has no complications, it probably isn't going to matter anyway, because what I was really concerned about was the fear that she was adrenally insufficient, and that's why she was hyponatremic. It happens also that on AM labs she was hyperkalemic. So you can imagine going to the surgical team and saying, here's a lady who has a significant change in her electrolytes on BMP. The pattern is consistent with adrenal insufficiency, and you're talking about doing a high-risk major vascular case. If everything goes perfectly, it probably won't matter, but as soon as we have an issue, such as you have to open up and she has that big stress response, then maybe we're not doing right by her. We need to work it up and figure out what's going on. So what did we do? We elected not to do the case that day. Let the medicine folks work her up, because you imagine the surgical teams aren't going to go through figuring that out, and came back and did her a few days later. Another case I have is a patient who was very ill, related to alcoholism, I think, but it certainly was liver insufficiency, up in endoscopy, and I think it was with Greg Buckler. And they needed to do a quick procedure, upper endoscopy, maybe an EGD or a bronchoscopy. And I said, the patient's obviously physiologically deranged, but I don't think in the near term we're going to be able to make this sodium any better. And maybe the patient was bleeding or had bled recently, so we kind of needed to do the case, but certainly we could have delayed it if I really pushed the issue. And what we found was the sodium was in the low 120s, and I explained that to the proceduralists who have many procedures to get through in a day in that line, that if we do the anesthetic, it'll probably be okay because there's almost no stress response to doing an endoscopy. But what will happen was the patient will be difficult to awaken, and it may be a very prolonged anesthetic time, meaning your procedure may only take 5 minutes, but my anesthesia may take half an hour. And are you okay with that? Because if you don't want to do this patient at the end of the day, and you want to keep your line going as scheduled, we may really hold you up just because of the price of doing the anesthesia. What we found was exactly that. Short 10-minute case. I'm not sure what they found, but nothing dramatic. Turned off whatever little bit of volatile we had running, and the patient slept for an hour before we could wake up enough to extubate. It was okay because we talked about the neurologic changes of severe hyponatremia and the implications for anesthesia. Because we were worried about cerebral edema, we were very cautious to not let the patient hypoventilate and not to use too much volatile anesthetic and cause increased vasodilation, since we wouldn't have good ICP monitoring, as you would guess, in endoscopy. Hopefully these help illustrate the relevance of the sodium. When you rotate through neurocritical care, every day we will talk about sodium. I rounded on Saturday just because of volume, and the only conversation I had directly with neurosurgery was related to sodium because it's so relevant to the way the brain recovers or people's mental status. Another complication or a relevant physiologic perturbation that you may see perioperatively relates to ADH, particularly because we do so many transphenodal pituitary resections at this point. Here's my personal notes that I lecture from in neurocritical care. If you think about all of our postoperative transphenodal patients, they go to the ICU afterwards, and that's most prominently to monitor for DI. So this is something we see routinely, and you'll get very comfortable in managing. Here are my notes on it. The main variables that you'll want to look for, particularly for an anesthesia exam, where they'll keep it very straightforward for you, is increased urine output. We use 250 or 300 mils per hour. So if you call me and say, well, the urine output's up a little bit, and it's after a transphenodal, the first thing I'll ask is, what's the urine output? Meaning I'm going to wait until it's a convincing number like 250 mils an hour to even start thinking about sending off labs. What you have in DI, diabetes insipidus, is increased urine output with dilute urine. The easiest way to evaluate that is to look at the specific gravity and use urine-specific gravity less than 1010, or what we're using currently, that's what I grew up on, what we're using currently is 1005, so a specific gravity less than 1.005. Because your patient's urinating out dilute urine, they become hemoconcentrated intravascularly, so what you see is a rising sodium, or at least a normal sodium. You won't expect to see sodium wasting at the same time because you don't have the ADH in your system, or because it's being inhibited. The diuretic effect is mostly free water. What do we volume resuscitate the patient most pressingly? Probably use half normal saline. We have it all protocolized out, and give some IV desmopressin or some sub-Q desmopressin to try to balance the system back out. Over time, it gets better in the vast majority of cases. You'll be asked about this clinically when you have, for example, a traumatic brain injury patient come in, and they'll start to dump a ton of urine. Mostly what we say is, because the reserves don't disappear instantly of the ADH, is that you don't see it for the first 6 hours or so. So intraoperatively you won't see it, but there have been a few cases where I see a massive diuresis during a crania, and I can't help but wonder if we're actually seeing DI in real time and not just in the ICU. Most of the time, if you bring that up to the surgical team, they'll say, no, it's too early, so I don't know what the right answer is. Here's a test question for you. A patient with a traumatic brain injury is receiving care in the neurocritical care unit. Urine output over the past 2 hours has increased to 275 mils per hour. Which of the following findings is most likely to confirm the diagnosis of diabetes insipidus? So I've given you a TBI with hypothalamic or pituitary injury. I've given you adequate urine output to diagnose DI. How are you going to confirm it based on the following? Is it a low urine-specific gravity? Is it a low serum osmolality, high serum brain natriuretic peptide, or high urine sodium? And although that probably sounds confusing if you're only listening, the low urine serum osmolality, that low urine specific gravity is probably the easiest way to confirm the diagnosis, that 1.010 or 1.005. High urine sodium would not be consistent with diabetes insipidus. I tend not to use the urine sodium because the range is so high, I don't know how to interpret it. So just picture me with normally functioning kidneys. If I have French fries for lunch, my sodium will be through the roof, and it doesn't mean anything's wrong. Granted, in the ICU we can control better what the nutritional intake is, but in general, I have a hard time interpreting it clinically when I have other things that are more reliable. And consider that our labs at UK don't even include a normal value for the sodium. Also related to perioperative sodium abnormalities is SIADH. In a lot of ways, it's the opposite of DI. If I define cerebral or central DI as insufficient ADH, the inappropriate ADH would be the opposite. So all the changes you would expect to see are pretty intuitive, or at least fairly intuitive. If you look up the list of things that are associated with SIADH, it's essentially everything. So I find it completely useless. So what I've written here is all of your patients are at risk for SIADH. Anything stressful and a whole ton of drugs can cause it. What do you see here? Increased serum volume. Could be normal or increased depending on their access to fluid, of course. decreased sodium, it's not entirely true, but the simplest way to think about this is that it just dilutes out because you're retaining the free water. If your serum osm goes down, your serum sodium does well as well. And when we have severe or refractory hyponatremia in the ICU, oftentimes this is when I start to think about differentiating SIADH versus DI, or SIADH versus cerebral salt wasting, or a combination of the two. And this is just something you'll have to memorize because you don't use it often enough, but demycycline is a classic answer because it actually induces nephrogenic DI to treat the SIADH. But now we have conivaptan and tolvaptan. These are vasopressin receptor antagonists. So very similar to the hypercortisolemia versus adrenal insufficiency, SIADH versus salt wasting versus diabetes insipidus, all can be paired up in your head so that you can keep them straight. In the ICU setting, you'll use conivaptan. The tolvaptan is more for outpatient. So if you just go through your head here to kind of practice and keep it straight and compare these variables that I have listed for DI versus SIADH, which you're much more likely to see perioperatively than you will see cerebral salt wasting, which is why it's excluded, you should be able to pretty quickly go through the differentiation. So let's just go on the DI side. For volume status, if the patient is urinating extra free water, then I expect their volume status to be down. SIADH, I would expect the volume status to be normal or up, depending on their access to fluid. For DI, their serum sodium, because the volume status is down, should be probably concentrated more, and the serum sodium should be up. Urine output obviously is up in DI, and the serum osms, related to sodium, of course, is the primary driver, is up. So what you end up seeing is that it's really easy to differentiate them. If you look at sodium, urine output, and osm, those are all up for DI and all down for SIADH. For the volume status, they're opposites as well, but the other direction. So for DI, the volume status is down. For SIADH, it's normal or increased. Switching off of sodium, because I think you've probably heard enough about sodium for a little bit. Just a few basic things on potassium. A survey from a few years ago, this is actually taken out of Pearls. I didn't reference the survey specifically, but I've seen it before. Asked anesthesiologists what level of hypokalemia are they comfortable with, and most people agree, in the way we teach it here, to ballpark is about 2.8. You may have heard Dr. Locke say, we're pretty comfortable unless it's less than 2.8 when the surgeons call and ask about it, if they can post the case or not. Requisite of this, however, though, is that we know what the potassium imbalance is from. Okay, if we have no idea where this came from, then maybe it's not appropriate to proceed at this time. Consider, there's been a lot of talk in this department about replacing the potassium and if it's more risk or benefit. And in general, a short bolus of potassium is more risk than it's going to help. So what I've written here is your total body potassium is 40 to 50 milliequivalents per kilogram. And I'm sure you're all familiar from your intern year of replacing potassium, maybe 10 milliequivalents, maybe 20 milliequivalents. Nowhere near, percentage-wise, a significant volume. And this is largely related to the fact that a lot of it is intracellular, it being the potassium. A large deficit is such a relative volume difference that you would need like an entire duration of hospitalization to replace the actual deficit. Otherwise, you're just changing the lab value. Is that physiologically relevant? It seems to be, because if you have someone who's throwing a lot of atrial irritability and you give them just 10 milliequivalents of potassium, maybe you've seen this in your clinical experience, you can get a normalization. But the key is that administering potassium is associated with many complications, including asystole, as we're all familiar, and may not be actually addressing the problem, may just be a short-term band-aid that's dangerous. I haven't replaced potassium in the operating room since I was a resident, if that helps put it in perspective for you. Consider also that what we do in the OR has effects on the serum potassium level. So let's, again, just take a neuro patient, since that's what I do most of, and you're doing a craniotomy for tuber and you're hyperventilating the patient. Well, if the patient's potassium starts at 2.8, and I'm going to go from 40 PaCO2 down to 30, then that hypokalemia may be very, very relevant because I'm going to drive that potassium intracellularly with the hyperventilation and may see more cardiovascular instability. Also consider that my mannitol may cause, at least briefly, a period of hypokalemia that may exacerbate it. Remember, this is clinically relevant. It may be hard to remember, but 0.6 milliequivalents change per 0.1 change in arterial pH. So, for example, if I hyperventilate enough to go from a pH of 7.4 to 7.5, which is very within my ability to do so with the neuro-OR, I get a change of potassium from 3.5 to 2.9. So you can see if I'm doing a neuro case that requires hyperventilation, and I'm already pretty aggressively hypokalemic, I may have to electively delay the case just to get things normalized so I don't cause instability during the operation. Another intraoperative thought that comes up on your test as well is something I have a hard time remembering, so I cheated and came up with the idea of scaredy cat. What happens to potassium when you administer ephedrine, epinephrine, albuterol, insulin? For me, these were all things I had the hardest time keeping straight in my head. The way I remember it is that the potassium, when there's a stressful state, such as giving a bolus of ephedrine or albuterol, which so often we give in this part of the country, when there's a stressful state, that potassium sees the stress and it goes intracellularly. What that means is if the patient is on ephedrine or norepinephrine plus being hyperventilated plus hypokalemia plus I had to give an albuterol, I'm doing a lot of things that are exacerbating that hypokalemia. So scaredy cat, when things get stressful, such as when you're administering pressors or inotropes, the potassium goes intracellularly and exacerbates hypokalemia. Hopefully that helps you keep it straight in your head. It's helped me a lot. For some reason, albuterol administration, potassium, I just couldn't keep in my head. Going to the other side here, here's just a classic case setup. 55-year-old end-stage renal disease, had a history of a stroke, chronically ill, and you do an RSI with succinylcholine. What you see here is the evolution. You started with the peak T waves going to what is starting to become a sine wave of hyperkalemia. You have to know how to do this. We've actually published on having residents get training on this and how it's helped. This needs to be second nature to you because it'll be life and death, and it'll be very short notice for you to realize what the problem is. So treatment of acute hyperkalemia. I think this is mostly from Randy Shell, so I put his name on the slide here. We're trying to shift the potassium intracellularly, so all of those things we just talked about can be used. Hyperventilation, it's hard because if they're already half coating, you don't want to hyperventilate and cut out the preload, but maybe if they're somewhat stable and you're starting to have peak T waves and starting to go less functional cardiac output, then maybe that's the right time to do it. You've all seen or have heard of giving the bolus of glucose and insulin. Remember, if you're in a code situation and we're not sure if the code is from hyperkalemia, to give the glucose first. The classic reason is if you lose an IV and you just gave 10 units of insulin, you could cause severe hypoglycemia. So that's why it's the same either way, you might as well give the glucose first. You can give inhaled beta agonists. We use calcium. There's a liver transplant going on right now, so they're rehearsing this in the room, I have no doubt. And you can increase potassium excretion with Lasix and Kioxalate. That's all I have for you. Hopefully I didn't use up too much of your time and you found something useful. Thank you very much.